don't have that, you will not be able to recognize these things. Okay? Also, I promise, I will not lead you astray. I will not tell you bullshit. I might let you stray a little and then talk about it in a couple minutes, but at the same time, I will not lead you down a bad path. Okay? Accelerated junctional rhythm, yes, it can be called SVT, but I'm not a crackhead, and I didn't just make that shit up. It's real, I promise. Okay? For real. So, all that being said, this...
So real quick, I'm just really curious about this hat. Was there like a career day?
Did we not just discuss that we are on a time crunch? I need you to, just forget about your squirrels and your hats, and let's move forward.
Let's do it.
Let's do it. All right.
Career day.
Jeez. Jeez, sorry. All right. So, this is junctional rhythm. Look at this real quick. We're going to just talk about this as a group. All right, weather's crappy. We're not flying them anywhere. 15 minutes from a non-cath capable ER and 45 minutes from a cath lab. Unresponsive 66-year-old male. What are we going to do? Pace them. Why are we going to pace them?
Because they need to be paced.
We got to get vital signs on this person. Why do we want to pace them, though? What specifically is happening? How do I know without a set of vitals that this guy's in trouble? His heart rate's 40 and he's unresponsive. Okay, those two items in and of itself scream, pace the hell out of me. Explain to me pacing. What am I going to set my amps at?
80 and 80.
80, and what's my rate going to be? 80. It is not wrong to go low and work your way up, though. Your book says 80 and 80. Talk to Dr. Usash when he's in next and ask him his opinion, because he is not an 80 person.
So for National Registry?
80.
Yes, ma'am.
Okay, so National Registry in the book say 80 and 80, but the ACLS says 60 and 60.
Yep.
So is it a start at 60 and work your way up?
If you walk in for registry and say 60 to 80, you're fine.
Okay.
Just do 70.
Never mind.
That range of 60 to 80 is acceptable for National Registry. Here, because ACLS right now says 60 and 60. Okay? The way I explain it to my students, because your book does say 80 and 80, just a very quick informational item. If you have a marathon runner and they're coming up to the finish line and they are exhausted, do you want to tell them to sprint? No. You want to tell them to jog, because they're going to be able to manage a lot more. So it's unacceptable in my mind as a provider to say, come on 80, when 60 is going to get that perfusion back that you need. And you can always increase if you need to. All right? Your book does say 80 and 80. It is not wrong. It is a preference thing. Good? All right. You're going to pace this person. After you pace them, what do you need to be doing for this person? It's more than just a rhythm issue here. What's going on?
Her atria's not working.
Manage your airway.
Please, let's manage this man's airway. I don't know what I have no information as to this guy's airway. And when you guys go in for your static cardiology, you're not either. You're going to see this crap. Okay, this is not enough information to truly effectively treat a patient, and it drives you guys nuts, but I do it for a reason. When you go into registry, you're only going to get just a tiny little bit of information. You have to be able to adequately treat. Okay, this guy, I know he's unresponsive. I have to do something with his airway. What is his respiratory rate? Respiratory rate is 18 a minute, and his pulse ox is 100%. Gorgeous. Let's go ahead and give him a nasal airway, right? Because now I've effectively managed his airway. He's maintaining it by himself. Well, he's breathing 6 times a minute, and his pulse ox is 60. Well, good howdy. Let's tube him, right? Does he have a gag reflex? Let's aggressively manage that airway. So these are things that you guys have to be considering. He's unresponsive at this time, but what do we need to have access to if we're pacing?
Your monitor.
Absolutely want to make sure that our monitor is good to go. We need to have an IV, Michael. Why do we need to have an IV? If I have to push meds. Yes, I'm controlling his heart. I'm hoping to control his heart. How do I know that I have effective control of his heart? Electrical and mechanical capture. Excellent. Thank you. Yes, you have to have both items, right? Electrical capture is what you see on the monitor, right? That the R's are coming up the way that you want them to. The rate that you set has the R's matching it up. Now, the electrical capture and mechanical capture is what you feel in a pulse. It should match the monitor. If it doesn't, you do not have electrical mechanical capture. Does everyone understand that there are two distinct parts that you have to know? Good. Okay. You need to get IV access. Absolutely. Is it going to be harder to get IV access after you begin pacing?
Yes,
Yes. Why?
because he's gonna jump.
He's going to be jerking around. Absolutely. If you need to effectively manage that airway, you want to be doing that as you're setting up to pace. Where do the pads need to be to pace?
Depends on manufacturer.
Front and the back.
Front and back.
Yes. 99% of the time it depends on the manufacturer. You really want to do front and back. Okay? And doesn't that make sense, really? Front and back? Because I have full control, right?
Shortest distance.
And it's the shortest distance, right? Okay, good. So this makes sense for pacing? Good. Any questions about this? Does everyone understand why this is a junctional rhythm? All right, very good, guys.
Pre-hospital 12-week blog has a good 2-part series on pacing
It does.
and making it successful. So
It's nice. It really does give a lot of good information.
it's fun.
All right, you're a single provider working and dispatched to a cardiac arrest with CPR in progress by police. The police advise that one shock has already been administered. You are 10 minutes away from a level 1 trauma center and 5 minutes away from a local hospital. You arrive to find this. What the hell is this? Ah! What is this?
Really
Is
fast.
there a pulse?
This is pulseless. This is a PEA. What is this, guys? Talk to me. What's that?
Is there a pulse?
SVT.
It's SVT, but it's a PEA. Remember I talked about calling items? This is an SVT with a condition of PEA, or a PEA with a condition of SVT. Remember I talked about style points? You guys need to know that it's a PEA. Okay, if there was a shock already administered, was it always in this?
We don't
No.
know.
No, we do know. We do know. Because there's only 2 shockable rhythms. VFib and VTAC. So is it always this rhythm? No. We know that defibrillation occurred because we know it in here. So we know that this rhythm changed. So we know that there's one rhythm change. If we have a rhythm that changed from a shockable rhythm to a non-shockable rhythm, is this good? No. Because what do we want to happen with defibrillation? What's the goal of defibrillation?
To reset.
To stop it, to then restart it, right? Okay, that didn't happen. Something got screwed up along the way. So now we are at PEA, okay, with a condition of SVT. Everyone understand that? Why is this SVT?
Because it's too fast to see.
Too fast to CP wave, which is why, Brian, it could be an accelerator or tachycardic junctional rhythm. We can't see the P waves. But yet the QRS complex is nice and tight, so we don't know it's not coming from the ventricles, right?
Yep.
But it's well over 100. Okay, that's where it gets a little frustrating. I know. All right. So again, we know that this is not ventricular in nature. We can't really see P waves. We can they're probably P waves, right? Probably. Would you guys agree with that?
Yeah, probably.
These are probably P waves, right in here. Definitively QRS complex T waves look a little peaked, maybe. Really hard to tell without a 12 lead at this instance. But we know that it's an SVT, but it's pulseless. What's the treatment for this? CPR. Walk me through it, guys. Come on, let's go. Let's mega code this guy. We're going to CPR. Manage airway. IV. Or IO. Better an IO than an IV, right? Because it's plug and play. Bless you. What's that? Epi. 1 milligram. 1 to 10,000. 1 to 1,000.
1 to 10,000.
1 to 10,000, right? Every 3 to 5 minutes max dose of? Till the cows come home.
Until you run out.
Right, until you have none left. Okay, or we do 3 rounds and we say this is not working. Whichever comes first, right? Okay, good. So yeah, so we're giving our epinephrine. We're looking for reversible causes. When you get into your ACLS textbook, you're going to talk about H's and T's. What are the H's and T's? I'm not asking for specific. What do they mean? What is that umbrella?
Reversible causes.
Reversible causes. How do I get this person out of cardiac arrest? Anything I can do pre-hospitally. It's like walking into the room and being like, so you guys good? Can I do anything for you? Are you good? It's like being a waitress. Okay? H's and T's are like being a waitress. Do you guys need anything? Can I get you anything? Are you guys good? You want some coffee? You want some glucose? Can I get you a little calcium maybe? Anything? Good? No? Good? For blanket? Okay. So any of these items. So these are our reversible causes that we can handle pre-hospitally. Okay? So realistically, until we get this person into a shockable rhythm or nothing at all, we're kind of screwed. Right? The biggest issue when you see something like this on the monitor and you cannot find a pulse, look harder. All right? Because chances are you're going to find a very faint, like femoral pulse when you get them into the ER. Did we do anything wrong by coding them? Because were they going to perfuse by themselves? No. Okay? It's not uncommon to be coding someone pre-hospitally, not able to find a pulse, get them into the ER, they get the Doppler out, and like, oh no, there's definitely a pulse there. Okay. Well, I was doing something wrong. No, you weren't. We just can't find it. Okay, and then we're not going to be perfusing well anyway. All right, any questions with this rhythm? Does everyone understand why we call this an SVT? Everything okay? Yeah? Does everyone understand the treatment for that? Can we give adenosine to this person?
I was about to ask that. Can you do?
No, because they're not perfusing.
Okay.
When you talk about doses, we joke around and say adenosine, or amiodarone comes as dead in the live doses, 300 milligrams versus 150 milligrams. The realistic part of this is that it's not dead or alive, it's perfusing or non-perfusing. This is a situation where it's non-perfusing. So adenosine does not have a non-perfusing dose. Okay? Because if you do have an SVT that has an issue with perfusion, but definitely has a pulse, are we going to be messing around with adenosine anyway? Probably not. What are we going to do? If it's really tacky. Cardiovert, thank you. Zap them. Seriously, it's like saying shocking. How do we shock someone? It's Thursday and I'm wearing my Monday underwear. Shocking. All right. Ooh, this is a good one. All right, check this one out. Oh, yeah. Oh, yeah. You and your ALS partner are dispatched for an unresponsive impulsive patient found in a park. You are the first provider to arrive and CPR has not been initiated. You are 30 minutes away from a cath lab and 20 minutes away from a non-cath capable ER.
What was your route time?
Okay, first of all, let's talk about the rhythm. What is this rhythm, Chris? L, not Chris S. So many Chris's. So many Mikes. And Freds and Eds and whatever the hell you are.
Only one Ed.
Fred Eds? Chris, what is
There's
this?
no pulse in PEA.
You're damn tootin'. Why are you working so hard? This is easy. This is absolutely easy. It's PEA. Right? Don't work hard if it has a rhythm, okay? And it is an obvious rhythm, but there's no pulse. It's PEA. The only time we say that it's not PEA and it's a non-perfusing rhythm is VTAC, V-fibroid systole. Okay? And technically, they are all PEAs. But we just don't call them that. It's another one to mess with your head, Brian. Sorry.
Thanks.
All right.
So
So.
the electrical conduction's there, but the muscle contraction's not.
Correct. Yeah. It's like the little engine that could, but the little engine couldn't. Yeah.
So-
This, jazz hands heart, is more ventricular fibrillation. Yeah. The electrical conduction of the heart is, it's trying really hard. It's just not.
So asystole is not a PEA, correct?
It is a form of PEA, technically speaking, and you have scholars going back and forth about this all the time. Because it could be an electrical activity that's very fine. It's where you get that very fine V-fib,
Then it'll be fine. Good day.
which is a form of asystole. I know. Yes, you're right. Yes. Yes. Yeah, no, yes, I'm sorry.
PEA.
Sorry, yes. Asystole is not electrical activity if it is an absolute straight line. Yes. All right? Okay. All right, so now we know that this is PEA, but what is this? What are we looking at? Do we have P waves?
No.
Mimic? We could look really hard, right? If we look really hard, pull out a microscope, right? And a magnifying glass and our bifocals, we might be able to find a P wave in this, right? But it's a freaking mess. This is a mess. What am I looking at? I don't know. It's PEA though. So let's talk. Are there P waves? Yes or no?
No.
Not really. Okay. We've got a really nasty baseline though. Would everyone agree with that?
Mhm.
That isoelectric line kind of makes you want to punch a baby? Makes you want to punch a baby. Okay. This is terrible. This is deplorable. So maybe we need to look at our lead connection, right? Okay. Were they sweaty? Were they fuzzy? Or are they gross? Those are like the big three. And then lead placement.
Windy.
Okay. So see what you can do to get a little bit of a cleaner line. Now obviously you're treating your patient while you're doing all this. You're not just stopping and be like, I'm sorry, I have to shave you, sir. Okay, you're going to be treating, in this case doing CPR. But yeah, it's a really just ugly baseline. All right, so now we're going to look for our P wave. We're really not finding anything. This is the cleanest one we can get. What about our QRS complexes? Because now we're thinking maybe this is not coming from the atria, right? If there's not a P wave here, we might not necessarily be coming from the atria. So let's look at our QRS complex. What do you think about our QRS complex? Is it wide?
No.
No, it's not wide. Bob, what do you think about the QRS complexes? I would say that the rate is regular. Would everyone agree with that? Okay, what else do you notice about the QRS complexes, Bob?
Some are a little bit shorter than the other ones.
They're all roughly the same. I would bet. Do you guys see this weird slur up here? Everyone see this, like, you need a magnifying glass with this funky slur?
It's like a rabbit ear.
Don't say that. I hate rabbit ears. Yes. Notch. Okay. This is indicative of a bundle branch block. You cannot diagnose a bundle branch block without doing a 12 lead. Okay. However, that being said, this is indicative that this person probably does have a bundle branch block. All right, that weird funky slur. We're going to get into 12 leads in about 5 minutes. We're going to talk about that a little bit further. Okay. This funky slur says to me that there's more going on than meets the eye. But the QRS complex is within normal limits, right? Did everyone agree with that? What is our normal limits?
What it says over there.
Less than 3 boxes.
Less than 3 boxes. How many boxes? Maybe 2, maybe less. Okay. So with this instance, our QRS complex is within normal limits. We probably don't have a P wave. Wait a minute. What's going on here?
Where?
We actually are going to call this depression. And the reason I kind of wanted to end on this one, this is a good place to kind of end our group discussion with this, is because this is not necessarily an inverted T wave. This is ST segment depression. Anything that is below the isoelectric line, significantly below the isoelectric line, is going to be considered depression, not inversion. When we're talking about the ST segment, we don't say ST segment inversion, we say depression. This is indicative of some form of an ischemic event. It might not be new. In fact, ST segment depression, when seen in specific leads, is more indicative of older damage. Older damage. So it's hard for me to say definitively what's going on with this person without a 12 lead. But I'm going to have a high index of suspicion, and I'm going to consider, right? I love my C words, right? Yeah. All right, I'm going to consider that this person probably has a bundle branch block and probably has some form of ischemia from some form of a myocardial event. So I know at some point they have some kind of damage, right? Make sense? Good, Mayor? Okay. Someone diagnose this for me. QRS complex is narrow. No P waves that we can see. It's going to be junctional. Brian?
Just a regular junctional rhythm.
Like 60, right? That's a 6-second stroke. It's about
Yep.
60, right? Okay. Now I'm going to completely piss you all off. Ready? Watch this. You're going to, this is when I, again, want to punch a baby. And I have a baby. I love my baby. This is probably a P wave. What the hell? That's not what we just talked about. No, that's not where it's supposed to be. This is probably a P wave. Okay?
That was that one
This is a
event.
displaced P wave. Pre-hospitally, without doing a 12 lead, we're not going to be able to definitively say that. But when you have a strange morphology in this area, okay, that's something you have to consider. That maybe the atria is not firing when it should. Okay? So again, if this is in fact a P wave, what does that tell you? could be a third-degree heart block. And this is where, look at, oh God, don't want to kill me. I'm just telling you what
No, I'm
it
just
is.
thinking.
All
That's-
right,
I'm just thinking.
dude, I'm getting like the death stare. It's not even funny. All right, so you have, again, these items might be P waves. Now, Kat, explain to me in a third-degree heart block why this could be a P wave and why that tells you it might be a third-degree heart block.
Because the P wave interval is gonna be the same, like P to P, and QRS will be the same R to R, but they won't match up together. They're not really, they're each following their own rhythm.
So when Sherry was in, because this is an old school way to remember this, and this is a very Sherry thing to say, and I don't say that with any malice because I love her and she makes me laugh so hard because her ways are so much better than what I was taught. So I think there was like a weird like Middle Ages in terms of EMS education where I just got lost in the shelf. I don't know. But either way, she told me that when she teaches complete heart blocks, that it's like a divorce. The atria and the ventricle get divorced. And I had never heard it described like that. But it makes a lot of sense. Because in a nasty divorce, mom and dad don't talk anymore, right? Wife and husband don't talk anymore. So a third-degree heart block, they're not talking anymore. So the atria is marching along doing its own thing with a regular atrial rate. And the ventricles are doing their own thing with a normal ventricle rate. But they're just off. They're not doing their own thing. If you map out these P waves, they're doing their own thing. If you match out these R to Rs, they're doing their own thing. So the QRS complexes are rhythm. Let me try that again. The QRS complexes are regular. Okay? The P waves are regular, which tells me that the QRS complexes, as in the ventricles, are regular. This is regular ventricular rhythm. Someone tell me the ventricular rhythm up here.
60.
What's the ventricular rhythm up here?
60.
Good. 60. Someone tell me the atrial rhythm up here and explain to me how you get it.
60.
Yeah, how'd you get it?
Because there's 6 P waves in a 6-second strip.
Yeah. Sometimes you're going to have the P waves be like 2 or 3 in between, okay? And we would say that that had increased. So if I see a P wave in a third-degree heart block where I have like P wave, God, that's not where I wanted it.
Didn't you just fix that?
Yeah, who was in charge? Oh, son of a bitch. All right, come here.
We'll tell Sim about it. Let's get engineering on that.
We would say if this was a third-degree heart block, okay, and we counted up the P waves, we would say it was an accelerated atrial rhythm in a third-degree block. Okay, so if you have atrial tachycardia in a third-degree block, you might have ventricular bradycardia too. They don't always have a 1-to-1 ratio, which gets really frustrating. Okay, I'm telling you this because you have to understand that there is more than just the basics out there. I'm not telling you this to frustrate you. I'm just letting you know because I felt like I was lied to when I found out that there was more to just the basics. I was like, no one told me this crap!
How would you distinguish that then between, say, atrial flutter?
Look at the
First.
morphology. Look at the P waves. It's like beautifully curved. And also, you're going to, depending on the marching, if you watch it long enough, the P wave will end up getting morphed and messed up into the QRS complex. Whereas in an atrial flutter, you're not going to see that. So the QRS complexes, the morphology of the QRS complex in third-degree heart blocks, can get funky. All right?
Good question.
Yes, ma'am.
P wave after the QRS, because maybe I'm thinking about something completely different. We were talking the other night about the P wave coming later or being upside down because it's coming from, the signal is like, say it's coming from the AV node and it's going down, but it's also going backwards and going up to fire the...
Are you talking about retrograde issues?
I'm not sure, but I
You
was
might be
thinking
talking
about
about
that.
retrograde
Is that how it looks too?
polarization.
It would be afterwards.
If you
and
see
upside
that, your patient is going to be a multiple medical problem patient.
down? Okay.
That's going to be very rare. That's typically a congenital defect. But yes,
Okay.
you can see it. Did you guys hear what she just asked?
Yeah.
Say it again.
Yeah, that was long.
Okay, just Reader's Digest version.
just we were talking about the, when the signal's coming from somewhere like the AV junction and it's going down like it's supposed to, but it's also going backwards up to fire the atria. She was saying that it was, people have multiple problems.
Can I erase this list on the side? Is that all right? And if I start writing over here, is everyone going to be able to see it? That's the bigger concern. Yes? Okay. Because it is 8 o'clock, and I will send this out, because I think this is important. But I do want to do some 12 lead stuff. Is that all right? Yeah? Okay. I do want to do some of this. I just want to lay the groundwork. So we already kind of started laying the groundwork. This is horrible. I am so upset right now. Why don't we have any spray?
You go across the hall and get an erase.
Do we have spray?
Some
Yeah.
water.
Where?
Expo spray? No.
That's not gonna help. All right.
Here, just.
The water never works.
Yes,
Water works.
just water. Something that's cold.
I got some.
I see all these.
There.
Does everyone remember what this is?
Yes.
What does IC all leads stand for, guys?
Where's your MI?
Inferior,
Septal,
septal,
anterior,
anterior,
lateral.
lateral.
Oh, look, the water works.
Thank you. All right, IC all leads, inferior, septal, anterior, and lateral. This is a quick mnemonic to remember when you see contiguous, meaning one right after the other. Contiguous ST segment elevation. ST segment elevation means that it's greater than what?
1 millimeter.
Greater than 1. One box, right?
No, I was,
Interior.
It's like, I'm sorry.
Just needs
Okay. So greater than 1 box.
interior
We
more.
see ST segment greater than 1 box in 2 or more contiguous leads. Then that's how we're going to diagnose the location of the MI. So tonight we're going to talk about ST segment elevation. We're going to start the discussion of ST segment depression. But I'm going to focus on elevation tonight. And I'm also going to focus on some mimics tonight. We're going to talk about left bundle branch blocks. We're going to talk about pericarditis. And we're going to talk about LVH, left ventricular hypertrophy. Okay, those are my three goals to cover. So again, we're doing ST segment elevation, left ventricular hypertrophy, ST segment elevation, and we're talking about LVH, and what's the other thing I said? Pericarditis. So, what does I stand for? Where it's inferior, but what are the leads that we look for to diagnose?
If you want to write on your hand to remind me, I have an extra tin file and both.
Awesome, thank you. This is easy. This is easy to remember. All you have to remember, ICL leads, okay, and then just fill it in. 2, 3, and AVF. If you can remember 2, 3, and AVF, the only thing you have to remember then is to go down the line, V1 through V6, 2 in each spot. That's all you got to do. All right, so this is an easy way to remember. And again, this is only talking about ST segment elevation. So if you have a patient with no ST segment elevation, does this help you?
No.
All right. So let's talk about the different windows that we want to look at when we're talking about a 12-lead EKG. All right. A lot of people kind of get screwed up because typically above this, what is listed? What's up here? Interpretation, or in some instances, you have the 3-lead being projected above it. Have you guys seen that? Where you have a 12-lead and you see the 3-lead projected right above it, and it kind of messes with your head. If that is a situation where your monitor at work is already set up to project the 3-lead above the 12-lead, don't freak out. Just fold it over until you're comfortable reading. Or put something to cover it. Get rid of your 3-lead, okay? Because you want to be so good that you can diagnose the rhythm off the 12-lead, and you also want to be looking for any changes. The first step of looking at this is identifying your boxes, your windows, okay? Because each one of these windows is going to tell you about a specific area of the heart. So, what is covered in this window right here, from here to here? What is this? What lead is this?
Lead 1.
Lead 1, right? Okay, what about this one?
2,
What about this one?
3.
Okay, what about this one? AVR. What about that one? What about this one? What is happening?
That's fancy.
What's this? Okay, it's really important to understand that when we're talking about everything, you're reading it just like you would a book. Okay, so when you see one, everything, when you're looking at it to the right, just like you read a book, okay, is going to be lead 1 up to our next point, which is AVR. So this is just like reading a book. To diagnose the rhythm, it is usually easiest to look at what you're most comfortable looking at. If your monitor at work is set to lead 2, you look to lead 2. If your monitor is set up for lead 3, look to lead 3. You only want to diagnose a rhythm off of those 2 areas. So let's take a second to diagnose this rhythm. Do you guys want to look at 2 or 3?
2.
2? Okay, so we're going to look at 2. So we're going to look at lead 2, which is here to here. So you're just looking at this. What is this rhythm? Talk to me a little bit. G, are there P waves in this rhythm? Are there QRS complexes in this rhythm? They are narrow. They look good. T waves in this rhythm? Okay. Is it regular? What is this rhythm? Are you saying it because someone else said it, or are you saying it because you know it? Good. Excellent. So this is absolutely a normal sinus rhythm. Okay? So, we know we've done half of our battle. So we know whatever we find in this rhythm, our underlying rhythm, is normal sinus rhythm. And it's very important when you are doing a 12 lead, the first step is to diagnose the underlying rhythm. And where are we going to do this? Lead 2 or lead 3? Does that make sense, guys? Good? Our next step is to begin reviewing our 12 lead strip. And you're going to look at the rhythms. Top, down, over, up. Okay, so top, down, over, up. Top, down, over, up. Oh, does that make sense? So we're going to start at lead 1. Start at the top, move down. 1, 2, 3. So top, down. As soon as we've done these 3, we're going to come over to AVR and go back down. So top, down, over, up. Okay? So let's start. In lead 1, anything significant here? What do you think? Chris, you're kind of like, The T waves totally do look peaked. I would absolutely say you are right. Let's wait and see if it's going to appear anywhere else, because sometimes things can appear one way, the morphology can be different, not because there's a problem with the heart, but because you're not used to looking at it at that angle. Okay? So it might be significant. Let's see if we see it anywhere else. So it's not, we noticed it, but it's not significant yet. So you see peak T waves in here. Yeah. Okay. Question, is this going to be normal sinus rhythm all over the place? In all the windows?
Yeah.
Why?
Should be,
Because
right?
normal sinus rhythm.
Right, it's not a different heart. You can only have one rhythm because you're only looking at one heart. You're going to have the same rhythm every window you look. It's the same house, different views. It's like a creeper. It's like a creeper peering in your window at night. Same family, different windows. Okay?
The part that got me is I see all these. I thought that's just one section of the heart. Like one side of the heart. So,
I see all leads is a mnemonic to diagnose from every angle of the heart. At the heart. Yeah.
so how is it, like if we see normal from one side, I automatically assume that it's going to be normal.
So, did everyone hear his question? The question was, if you see one angle of the heart and it looks normal, how do we know that it's not going to be normal elsewhere, correct?
Right.
Okay. We have to look at all angles. Think about it this way, back to my house method. If you're a creeper and you're a peeper, okay? And you're looking in different areas, different windows of someone's home. You come downstairs and you look in the kitchen, okay, and mom is making dinner. Is there a problem
No.
in that house? Is that a problem? No, that's one angle. That's fine. You go upstairs to the first bedroom and there's a kid doing their homework. Is that a problem? Is this family an issue? No. We go into the back bedroom and there's teenagers snorting cocaine. Is that a problem? I didn't know that that was a problem until I looked at the right place. Things can look normal until you look at the right place.
You just said 30 seconds ago that if you're reading from lead 2, normal sinus rhythm, you're going to see that it's going to be normal sinus everywhere else.
So that's the underlying rhythm, okay? So it's going to be normal sinus rhythm everywhere because it's only one heart, okay? When we're talking about diagnosing off of different areas of the heart, we're looking for specific things within that normal sinus rhythm that are going to jump off the page and say, okay, now there's a problem, like ST segment elevation, peak T waves, ST segment depression, elongated QRS complexes, okay? Yeah, so the underlying rhythm is totally fine to diagnose off of lead 2 or 3. Does that make sense? Is that one good, guys? Do you guys hear that? Is that okay?
Yeah.
Okay, all right. Okay, so we're going to start top down and go up. So 1 is fine. Any issues here in lead 2?
I have a question with 1.
Yes, question with 1.
Why are QRSs look like small?
QRSs look small. They look like a low amplitude just because of the angle you're looking at the heart.
Oh.
Yeah, that's all it is. And remember, it's like taking a picture from Earth up at the sky with a different type of telescope. You're going to see a different view in Hawaii than you're going to see in the Arctic. That's all there is, okay? So V1, it looks different, but all the objects are there to diagnose 12 lead. Do we see any ST segment elevation? We do? Okay, so all yes, and I was like, ooh. Okay, so no ST segment elevation. Morphology, the T wave's a little funky. Yeah, remember when I say morphology, I'm talking shape, right? Maybe a little funky. Maybe that's just the way we're looking at it. We're gonna have to come back to that. So top down. No, we move on to lead 2. Any issues here in lead 2?
No.
Totally peak T waves. Now I confirmed 2 peak T waves. 2 peak T waves in 2 places. So now am I thinking it might just be an angle issue?
No.
Now I have a high index of suspicion, or I'm considering that this is an issue because I've confirmed it in 2 different places. Now we're going to come down here to lead 3. Any issues down here in lead 3?
Yeah.
What's our issue in lead 3?
There's no P waves.
P waves are kind of.
Yeah,
Kinda artifact.
the amplitude of the P wave is like gone. But now here's the cool thing with the 12 lead. If this were a 3 lead, right, if all I saw on my monitor was this, because remember, a lot of us use 3 lead to diagnose just regularly, that almost looks junctional, doesn't it? Because I can't see a P wave, okay? But wait a minute, I have to look at the whole heart. The P waves are there. And when I trace down, because remember, this is the same beat that we're looking at, I can totally find the P waves if I come back down. This little blur right here is totally a P wave. This right here, when I trace it down, this is a P wave. It's just inverted down at this one. So the P wave's there. I would not have been able to see that in lead 3 if I was just looking at lead 3. But I'm not looking at just lead 3 now. I'm looking at lead 1, 2, and 3. Does that make sense?
Mm-hmm.
You guys starting to understand why it's so important to get a 12 lead? Okay? Because God forbid I had someone with chest pain, okay, and there's slightly bradycardic sinus tach. And I diagnosed them without doing a 12 lead of a junctional bradycardia or junctional rhythm, and I start treating them like a junctional. Is that the right method? Might be the right treatment. Bradycardia is bradycardia, right? At the same time, am I going to look like this when I walk into the ER like, my patient's in junctional rhythm? And they do a 12 lead and they're like, no, they're not. Right there. Okay, that's why it's important to do a 12 lead. All right, so we come down. What's our next step? What's the next window I look at?
AVR.
Good, because top, down, over 1, and up. So now my next place is AVR. So let's look at AVR. What do we notice about AVR right away?
It's inverted.
It's inverted, absolutely. What's it? Remember, we don't say it's inverted. We say it's
Depressed.
a negative deflection. Good.
Or depressed.
We say that it could be depressed. Okay. It's not depressed in this instant, though. We say that this is inverted because yes, it's below the
Upside down.
isoelectric line, but it starts at the isoelectric line. Does that make sense? If it started below the isoelectric line, then we would say that it was depressed. This doesn't though. Look at that. It starts right at the isoelectric line. So in this instance, we're going to say it's an inverted. And AVR is always going to appear inverted. AVR is always going to appear inverted unless you place your leads wrong. Okay. Everyone's like, I'll write that down. All right, so AVR. Do we see P waves? Do we know for a fact our P waves have to be there?
Yes.
Because this beat is actually this beat, is this beat, is this beat. Does that make sense? We're looking at the same 3 beats everywhere. We are only taking a snapshot of 3 beats with this heart. That's out of control. This beat is actually this beat, is actually this beat, is actually this beat. Is actually this beat, is actually this beat, is actually this beat, is actually this beat. Does that make sense? You're only looking at 3 beats. This is crazy. This is a lot of information to get after 3 little tiny beats, isn't it? All right. So we have an inverted T wave here, reverse T segment. We have our QRS complex looking nice and tight. We know that there is a P wave there because we know there's a P wave over here, so that's easy. Nothing clinically significant here that I can see in AVR. It's my first time looking at an AVR, so I'm a little like, oh no, but nothing's jumping off the page at you guys, right? Nothing's like, holy crap, that's a problem, right? If you're not holy crapping, it's probably okay. All right, come on down to AVL with me, because remember, top down, bottom up, top down. All right, so we're going to go over here, AVL. This looks all kinds of funky. I don't even know what I'm looking at. How do I know that there's a P wave in there?
Because it was there before.
Because it was there before, so it's got to